Hello and welcome back to the second part of the Adverse Drug Reactions screencast for PM1C. Hopefully you've had a chance to think about the answer to those first three questions, and we'll go through those in the next three slides. So before a new drug is marketed, typically it's tested on between 1,000 and 2,000 patients. So the answer here is about 1,500 patients. So they are tested for their efficacy to see whether they'll work, and they're tested for their safety. But if you think back to the types of drug reactions that are rare or very rare, those types of reactions that only happen in 1 in 10,000 patients, they probably will not be seen in clinical trials. And also thinking back to your type B, your idiosyncratic type of reactions, which are also fairly rare, they will also not be seen in clinical trials, or unlikely to be seen in clinical trials. Therefore, this leads into what the focus of the second part of the lecture is, that once a medicine is on the market, that's where you're more likely to see the adverse drug reaction profile of that medicine. And that's why when medicines first come to market, we need to keep a very close eye on the types of adverse drug reactions that patients may be experiencing, and that's what builds up the side effect profile in the BNF when you look for that medicine for when you're going to be counselling a patient on it. And for the clinical trials, so on those 1,000 to 2,000 patients that clinical trials are undertaken on, typically it's always been done in normal healthy individuals and in patients who have no other diseases. However, typically when a medicine is brought out to the market, that's not the population that is taking the medicines. Most prescriptions are given to either children or to elderly patients. And we've already said that the children and the elderly are more at risk of developing adverse reactions. Also, it's not ethical to test medicines in pregnant in individuals because of the risk to the mother and the risk to the baby. And for any clinical trials that typically the early stage of clinical trials, they'll only be able to pick up things that you could actually measure. So if you were doing a trial and giving a medicine to a rat or a mouse, something like that, you certainly be able to see if that animal has diarrhea, if they have a dry mouth. And when after the end of the trials, when they potentially look at the animal or dissect the animal, you'd be able to have a look whether there's any liver toxicity or heart damage or any kind of organ damage. But what you probably won't be able to tell is whether that animal is experiencing a headache, or whether they're having any kind of depression or suicidal thoughts, or any of those kind of serious side effects that actually are very subjective. And you probably would want to know about those before you start the clinical trials in humans or on a much larger population. So clinical trials are useful. You obviously have to go through those through the process of marketing a medicine, but at the point where a medicine comes to market, we do not know the full picture of whether that medicine is completely safe to be used in humans. And in the next few slides, we'll give some examples about where actually it was only once it was brought to the market that we realised that they had these disastrous adverse drug reactions. So what we're talking about here is that post-marketing surveillance. So once it's come to market, it's being used in a large populations of patients. This is where the surveillance of the medicines is really key to collect data for the medicines to report the adverse drug reactions, and that's why that helps improve the patient safety and the profile of each of those medicines, and knowing which is the safest medicine to use in different populations of patients. So I'm sure you've all heard about thalidomide and heard about babies that were born as a result of mothers taking thalidomide during pregnancy. So it was first brought out in the 1950s in the clinical trials. It was seen to be very safe, and it was used by a lot of mothers to combat morning sickness. However, they started noticing babies who were born with these deformities, and reports were being kind of coming in various places, but there was no central system to collate those reports, to attribute those reports, or to look back at what had been causing these congenital malformations. And the drug was on the market for nearly 5 years before anyone associated or anyone collated all of that information and realised that it could well have been down to this medicine that these mothers were taking during pregnancy, and it affected thousands of children. It was it almost was the side effect that led to the introduction of the yellow card reporting system. It said that we needed a central body that was independent from the pharmaceutical industry, that would manage the reporting and the safety of medicines, and that's what prompted the establishment of this yellow card adverse drug reaction reporting scheme. So the yellow card reporting scheme is run by the MHRA, the Medicines Healthcare Regulatory Authority, and it collects all reports of adverse drug reactions to medicines. And it's really helpful to identify some of those reactions that perhaps only happen in 1 in 5,000 or 1 in 10,000 patients. And also, when you report an adverse reaction, you'll give the history. So you'll say how old the patient is, what other drugs they're on, what ethnicity they are, for example. And so we can look at what some of the predisposing factors are. So is this adverse drug reaction more likely to happen in an elderly population? Is it more likely to happen if the patient has renal impairment, for example? Is it more likely to happen if the patient is also taking a non-steroidal anti-inflammatory drugs? It may be used to compare drugs within the same therapeutic class. So we've mentioned already about the non-steroidal anti-inflammatory drugs and how they increase the risk of patients having a GI bleed or increases the risks of having a heart attack or a stroke. So we can look at how many adverse drug yellow card reports there have been for each of those medicines within their class. So it might say that, say, for diclofenac, there has been 50,000 reports of a stroke with patients taking it, compared to ibuprofen, where there's 20,000 cases of reports of adverse drug reactions. So you'll know in that case that then one of those is safer to use than the other one because it has less reports of that side effects. And it gives you an example of how the whole time that a drug is on the market, so even the drugs now that have been on the market for many, many years, 20, 30 years, it's still appropriate to report any serious adverse drug reactions for those. We can continually collect that information for those drugs. So the next time you have a BNF in your hand, please do just flick to the back of the BNF. There's a yellow card, a paper yellow card in the back of there. Have a look at the information that you need to record on it. So if you're working in a community pharmacy, if you're working in a hospital pharmacy, if a patient presents to you with a serious adverse drug reaction, you can fill this in yourself and you can send this off to the MHRA. Most of the time now, most of the reports are done through their website, so you can log on and register all the details on there. When it was first set up, it was just the doctors and dentists and then coroners that were allowed to do it. But from 1997 and 1999, community and hospital pharmacists can now report adverse drug reactions. And actually, most of them at the moment are reported via pharmacists. Typically, doctors or dentists perhaps don't see it as a priority or don't see that they have time. But us as pharmacists, as the experts in medicines, we all must have this responsibility to report adverse drug reactions. And since 2005, members of the public have also been able to go online and report an adverse reaction they may have had at home to a medicine. So since the introduction of the yellow card scheme, there's been over 400,000 reports of adverse drug reactions to the MHRA, but they suspect that actually only 2 to 4% of adverse drug reactions are actually reported, and only 10% of those that are serious are reported. And this may be due to lack of time. So we spend a lot of time managing the adverse drug reaction, making sure the patient is okay, the patient, the side effect or the adverse event is managed, the patient survives or recovers from that adverse reaction. In fact, we perhaps don't take the time out to report it. Sometimes the patient doesn't report the adverse reaction, so they have the adverse drug reaction at home, but they don't necessarily tell the doctor or the pharmacist about it. But the more that we report it, the more information that we can gather on that medicine, and the safer we can make the use of that medicine for patients. So these are a couple of examples of medicines where actually reporting of the adverse drug reactions have led to changes in them. So rofecoxib is a COX-2 inhibitor, and it was brought out in the 1990s as almost because a lot of the non-steroidals that we've mentioned already increase the risk of GI events. The COX-2 inhibitors were thought to be the kind of new wonder drug. They worked in a similar fashion. They were very good as painkillers, as anti-inflammatories, and they didn't have the same GI side effects. But actually within a few years of them being on the market, so within 5 years, they had a significant increase of heart attack and stroke for patients, and it led to that the rofecoxib being withdrawn from the market as a result of significant adverse drug reactions. Alendronic acid is a medicine. It's a bisphosphonate medicine. It's typically taken once a week, and it's used to prevent osteoporosis in patients. And what they noticed when it was brought to the market in 1995 is that a lot of patients were having esophageal reactions. So the tablet was getting stuck in the patient's esophagus. It was causing ulcers or burns or tears in the esophagus. And although it was quite a severe adverse drug reaction, what they realised is that they revised the dosing instructions, which meant that when you dispense it in your PANSS class or you dispense it in community, on the label it comes with lots of information. So it says this medicine must be taken with a full glass of water, or the patient is sat upright or standing, and the patient must then remain standing or sat up for at least 30 minutes after taking this medicine. And that's to make sure that once the medicine is taken, it is taken all the way down from the esophagus into the stomach. So if you took medicine and lay down, you might be at risk of these throat reactions. So this one, it stayed as a product. It wasn't withdrawn from the market, but they amended the instructions to make sure that it was safe to take. So in order to report an adverse drug reaction, we have to first of all be aware that the adverse drug reaction is occurring and identify it. So adverse drug reactions are most likely to happen perhaps after a new drug has been started, or whether the dose has just been increased. So you've just handed out a prescription to a patient, and they come back within a day or two, or their dose has just been increased, and they come back to the pharmacy. I'm experiencing severe nausea, headaches, I've got a skin reaction that's developed, and they've just started new medicine. Then that's a key indicator that they're experiencing adverse drug reaction. If they stop the medicine and it goes away, thinking back to your type A and your type B adverse drug reactions, then that gives you a big clue that it is that medicine that's causing it. And sometimes, but not very often, the drug might be restarted and then it reappears. So obviously if it was a type B type reaction, you would never restart that drug. You may be able to do some lab tests or some clinical measurements, for example, the patient's blood pressure, their liver function, their full blood count, and that would again give you an indication of the type of drug reaction that's happening as well. It's really important that we get a full history from the medicine, so from the patient, so a full history of other diseases, of other medicines that are taken that could be responsible for it, and review all of the medicines, so which of these medicines are most likely to be implicated and causing that adverse drug reaction, but also being aware perhaps of drug interactions that may have increased the risk of that patient having a adverse drug reaction as well. So not every side effect or not every adverse drug reaction needs to be reported to the MHRA. So what they're asking for is any adverse drug reaction that is fatal, so where it has caused death of the patient, or it's life-threatening, or it's caused the patient to be admitted to hospital, or cause any medically significant effect. And on the next slide, I have an example of what are the medically significant adverse drug reactions. And we also talk about what black triangle drugs are. And in the BNF, in some drugs next to the preparation, you'll see this inverted black triangle, and we'll talk on the next couple of slides what that means. So any new drug, when it comes to the market, after it's undergone the clinical trials looking at safety and efficacy, is given a black triangle, and they may have that black triangle for just a year or so, or it might be a long-term part that goes alongside that medicine. And if it's got a black triangle, any adverse drug reaction related to that medicine must be reported to the MHRA, because that's their starting point for them to collect all of the data for that medicine. Sometimes a drug has been on the market for a long period of time, but actually say for like simvastatin, which is used for patients' cholesterol, but if that's given in a new way or for a new indication, or it's being given in combination with another medicine, then that can also become a black triangle drug until the MHRA have collected sufficient reports to determine the safety of that medicine. And then this table here shows what the MHRA classes as medically significant adverse drug reactions. So if the patient has any kind of blood discrepancies, so you look at their full blood count and there's any significant changes in their white cell count, their platelets, if they become anemic, if they have any clotting disorders, if they have anything that changes their heart rate or their blood pressure, for example, hallucinations or epilepsy, anything that causes hemorrhage or liver dysfunction, and you can have a look at the rest of the list as well when you're at home. So any of these are classed as medically significant or clinically significant events, and if a patient experiences any of these as a result of the medicines, it must always be reported to the MHRA, regardless of whether that medicine has just been released onto the market or it's been on the market for a very long period of time. So we're just coming to the end of the second part of the adverse drug reactions for PM1C. So in part 1 and part 2, we've talked about what an adverse drug reaction is, the types of adverse drug reactions, how you might interpret side effects or adverse drug reactions in the BNF. So thinking about telling the patients about the most common types of adverse drug reactions and the rare or the significant ones. So if you develop this, you must report it straight away to the GP. We've talked about when a patient presents to you with an adverse drug reaction, how you might manage that, how you might investigate it, find out all the other predisposing factors that might be causing the adverse drug reaction, and why it's really important that if a patient does present in hospital or in your community pharmacy, that we report an adverse drug reaction on a yellow card to the MHRA so we can gather further information about that medicine and its usage and its safety. So when you're in your PM1B and PM1C workshops the remainder of this term, you're going to be doing some dispensing, and you're going to be preparing to counsel a patient and responding to symptom consultations. Think about how you, when you recommend a product or you dispense a product to the patient, it's really important that we counsel them on the side effects of the medicines so that they are aware if they have a side effect, if they have an adverse event, what to do about it. Can they manage it at home? Do they need to report it to the pharmacist? Do they need to report it to the doctor? How common or how rare is that side effect, and how you might explain that to a patient without scaring them. Okay, so and as time goes on, as you move from first year to second year to third and fourth year, you'll be working more on your consultation skills, and in your final year you'll be doing consultations or mock consultations, looking at counselling patients on their medicines, which will include those side effects. When you're on a placement, either at perhaps the Royal Berkshire Hospital or in a community pharmacy, or if you get experience in a pharmacy either as a volunteer or in the summer, thinking about common drugs that might cause adverse drug reactions. So those top 10 adverse drugs that can cause adverse reactions and admissions to hospital, identifying patients that are on those, thinking about your elderly patients, your very young patients, and patients that may come into your pharmacy or into the hospital with an adverse drug reaction, and how they should be managed appropriately. So thank you very much for listening to this screencast on adverse drug reactions. These are the references that have been used in this lecture, and if you have any questions at all about adverse drug reactions, please feel free to email me. Thank you very much. Take care.